Okay, welcome everybody. Thanks for taking time out from your lunch break to listen to the latest of our Intensive Care Society wellbeing webinars. This one's about care after incidents. Just a little bit of housekeeping for you. As a participant, we can't see you. Your video and is off and you're muted. If you do have questions for us, please put them in the Q&A function. Please try and avoid the chat because it's quite distracting and it pops up on us. This is being recorded, so just to make you aware of it, and it will be shared again afterwards. So welcome. Today's our session on care after incidents. So I am joined by a lovely panel. We're an all-female panel today. So most of you, I hope, would know me. I'm the National Wellbeing Project Director for the Society. I'm also a jobbing consultant clinical psychologist in Cardiff. I'm joined by Dr. Fiona Kelly, a consultant in intensive care medicine from Bath, and big thanks to Fiona for the original concept of this tool and for bringing this tool to the Society to help us kind of develop it further. She'll be joined by her anaesthetics registrar, Fran Millencham. I don't know if I've actually said that properly. I've never said your surname before, so I hope I've said that right. And then I'm joined by two of my very lovely colleagues from Cardiff who've been trying to pilot this tool with me. So Dr. Sarah Catherine Cook, who's another consultant in intensive care medicine, and Neve Sully, who's one of our fantastic staff nurses in Cardiff. So the order of events for today is, first you're going to hear from me. I'm going to give you a bit of an introduction. What is the tool? A bit of a theory behind the tool. And I'm very happy to say we've also got a little scenario that's been videoed to share as well. Then we're going to listen to Fiona and Fran talk about their experience in Bath and how they've already been rolling out that tool in a slightly smaller ICU. Sarah and Neve join me from Cardiff. We have a bit of a bigger tool and we're slightly further behind, so we wanted to reflect on kind of the pros and cons of rolling it out in a larger ICU. And then we've got the last 20 minutes to kind of talk to you guys about what you think about this tool, any questions and answers, and maybe about how you might take this forward on your own unit. So first of all, what's the TIM? There's a really good photo of my friend Shagan there, who's a very good communicator. So the TIM will get nicknamed a debrief tool, no matter how hard we try. It is a communication tool. Really, the intention is it's for use following any clinical event that may cause distress. So we're going to go into what is the tool and what is the kind of theory behind that communication. But while we mention the word debrief, let's get into a little bit of a reminder of the debriefing evidence base. Do we debrief or not? Well, we say we do when we probably shouldn't. And I guess there's quite a contentious kind of evidence base around this. And one of the things that I have learned more about recently through working with a fantastic guy called Walter Epic is about intention behind debriefing. So it's all about what we intend to achieve when we're having conversations with people. And when we're debriefing, if we're intending to help, intending to help people perform better, to recognize errors or learn, to prevent psychological trauma, to offer peer support, to offer space to reflect. And there's a big difference between a clinical debrief and a psychological debrief. For one, we really want a psychological debrief to be led by a trained psychologist. The intention usually around psychological debriefing is intention to manage the aftermath and symptoms following a difficult event at work, and sometimes it's the intention to intervene. And it's the intention to intervene that comes with the rather troubling and variable evidence base. However, the clinical debrief, where the intention is to come together and reflect and learn, has actually quite a strong and positive evidence base. And that's really important that we think about that and where the TIM sits within that. So here's a really recent paper that talks about that, and it talks about those learning orientated debriefings, really good for supporting patient care. But when we're thinking about that intention to prevent PTSD and intervene, that's not recommended. But it is worth knowing that events cause distress. And if when we're reflecting with people and debriefing with people, we see signs of distress, we need to learn from, we need to shift from a learning perspective to a managing perspective. So we bear this in mind when we designed the TIM tool. So here's just some of that evidence base around why we don't use it as a tool to intervene with PTSD. Not a lot of evidence in terms of kind of the treatment of PTSD. There is a strengthening case for early routine detection for people exposed to traumatic events. This is really, really key, because TIM is part of that initial checking in and kind of detecting if someone's going to struggle. So here's from the Kolb paper. I won't go into it in any great detail, but it's worth looking up this paper and looking at that position in terms of where the TIM sits. And it sits somewhere between that intention to learn and that intention to manage. So if we think about that in terms of the whole raft of measures that are out there, so we in the society really advocate that if we're to give people a good experience of work and be promoting of good well-being and preventative of psychological harm, we need the base of that triangle. We need the core conditions to thrive, the resources, the education, and the psychologically informed leadership to do our job well. We're in the society, and we certainly also do it in Cardiff. We have a peer support initiative where we encourage and train people who have a well-being mind to look out for and check in with other colleagues. In England, there's the Professional Nurse Advocate initiative that also sits in that position. TIM sits as a tool that anyone can use clinically. And for those of you who use TRIM, it is an accidental name similarity there. But for those of you who use TIM, and Fiona will talk about this a little bit more, TIM can link in to your TRIM program really well. In Cardiff, we don't have TRIM, but TIM links into, for us, the reflective case discussion and that one-to-one support. So TIM acts as that care after incident communication tool to check in with each other and then potentially link to the possibilities for that, what we call cold debrief, or that reflective discussion, that assessment of trauma risk, which is TRIM, and potential for one-to-one support if needed. The other key thing from an evidence-based point of view that the TIM uses is something that we call psychological first aid, which actually has got a lot of grounds in the pandemic, but is from, it has a long-standing evidence-based and is used for care after incidents by the World Health Organization. And it's about that practical and supportive assistance for distress after an incident. And the key principles are look, listen, link, which have informed our TIM tool. We look out for each other, we listen and hear what each other have experienced, and we make those links to further support and further ideas if needed. So enough of the theory, let's get to the tools, the reason why you're all here. So it's a team event. You know, I am a psychologist, but this isn't a psychology-driven tool. It doesn't have to be a senior leadership-driven tool. This is something that anyone can do, and it's something that we do as a team together. So as I say, the purpose is it's for communication. It's to allow an ad hoc group check-in following any clinical event that causes distress, which people sometimes call hot debriefs, but our intention is we're acknowledging, we're checking in, we're monitoring, and we're offering that link to psychological first aid. So when do we use it? Well, it's not supposed to be something we used all the time. It's an ad hoc, and anyone can ask for it at any time, any clinical event that causes distress. Anyone can lead it, although we'll share our reflections about people's confidence in leading these. It's intended as a group conversation, but we have run some simulations where we see it actually works well as a one-to-one or a one-to-two as well. We take you through 3 stages on the first page. People are then linked on to either one-to-one support, reflective team support, or potential trim if you have that in your organisation. And people are linked to psychological first aid, which is the second page of the tool. A key part is it's voluntary. This isn't something we're going to mandate to people to do. It's something that you use in the moment, ad hoc, and it's a useful tool, but it's not for everyone. So what kind of events? Well, it can be any event. Some of the ones that we pulled together is it could quite often be after an arrest or an unexpected death, but it also could be used in incidents such as drug error, especially if it's a first-time incident for that member of staff. We've also simmed it around rudeness and incivility and found it to be really useful there. But the key thing is it could be used in any event that's requested. So here's the tool. So as you can see, it's beautifully laid out by our folks at the Intensive Care Society with their magic wands. And the 3 stages are prepare, meet, follow up. So in prepare, there is an event and we pause. We stop, we assemble the team. It's absolutely fine to assemble that team at the bedside or just kind of nearby to the bedside. So you've still got a clinical eye out for your patients. The aim is for 2 to 3 minutes, and our simulations have shown it's about 2 minutes 20 we've got it as. And someone is chosen, someone either self-assigns or you assign someone to lead the team by quite literally scan the QR code, pull the laminate off the wall and say, hey guys, let's get together and let's stop and assemble for a couple of minutes. In the meeting, first of all, start with thank you, always really important. Second part, what happened? And it's good to focus on just facts, not opinion. It's really key at this stage that we aren't getting into the who said what, who did what, or assigning any causality because of that risk for potential blame. And that's a key thing from the PTSD literature. We don't want to be putting into people's minds, what could I've done, what have I done wrong, etc., because we know that that is something that can start to play on people's minds at this point. So we keep it super succinct and factual, but we do make that statement that we are human. And I hope you're okay, but it's okay if you're not, because any such event could make you feel shook up. And there's the common feelings, which we'll come to in just a second. And then you link for the follow-up. So we have different ways of doing it across Cardiff and Bath. You can find your own way of doing that. We've found a QR code for writing a list of people involved. Seems to be the way forward, linked to an MS Forms. On your kind of laminate, you can have email the list to. You could have your QR code there. But really key is you take just a few moments for yourself, a break if possible, and you look to the information overleaf. And that's this stuff. This is the psychological first aid. So we know, although we say to people, gosh, that incident broke me and goodness me, you know, I feel awful and that's a, you know, that's my problem. Actually, This is everyone's experience. Even the most experienced people may feel shook up after a clinical event. Remembering is common. We remember in different ways, but usually in intrusive ways. So either thoughts that pop into your mind during the day or thoughts that pop into your mind at night time. And although a lot of people think I should be over it by now, actually it can take anything up to 4 weeks. That's the evidence base. And it's key that actually people do seek help if it's not resolving within 4 weeks. But that evidence from early intervention, you can seek help earlier if you want to. It's a personal choice. Much as people think it's good to talk about these things, actually it's not always. And it's a balance. And I sort of say titrate the emotion, really. It's that balance between thinking and allowing it and taking a step back and just getting on with something else and distracting yourself. So we say keep a balance of that avoidance. We do know, and obviously we've seen this in the last 2 years, one event can cause distress. Repeated multiple events can increase that effect. And certainly I think there are still some people who have some lingering intrusive memories of what they've seen over their many years of work, but certainly the last 2 years. So what do? Practical, useful actions that are evidence-based. Well, we know that actually if you just push it to one side too quickly and don't give it a little bit of headspace to process it, you're more likely to have lingering effects. So we say don't go home straight away if it's the end of the shift. Check in with someone, talk to someone you trust, and certainly if you're going to home after a night shift, put it to bed before you go to bed. So maybe for some people, they want to have a chat about it. They may just want to give it some headspace. Some people, it suits them to write it down. Key thing from the evidence base is we're not very good at caring for ourselves, but we're really good at working out what other people need. So treat yourself as your best friend. Actually activates that part of your brain that makes you think about what it is you need. And it goes beyond saying that what it is you probably need is some simple, positive self-care and no pressure. Bit of sleep, little bit of fresh air, connect to the people that you care about. From a team care point of view, we should keep our eyes out for everyone. Think about, the healthcare support worker, the cleaner, the admin team, etc. Cast that net widely, look out for the people on the periphery who are quiet, and we take that approach of looking after yourself and let's look out for each other. So that's it all, nice and simple. You'll see it simmed in a moment and you'll see how simple it can be. This is going to be available to you, but this is just a suggested form for follow-up. So nice and simple, totally optional, just your name and contact email. Just to say, on its way is a JICS paper. It's in review, in process. So we'll have a bit more detail. So thanks to Fiona and the gang for writing that up. That's fantastic. And also, big up to Fiona's trainees who have been awarded an Association of Anaesthetists award for this. So fantastic stuff. Someone's in the background making some noise there. Okay, so I'm going to stop sharing this and then I'm just going to show you. I hope it works. I'm going to show you a simulation. Can you give me a thumbs up? Can you see that? Yeah, I'll press play.
Let's get together. That was a really hard situation. Let's just meet and have a quick chat. Sarah, can you explain what happened?
So fact of the case, 48-year-old who's come into us for severe pancreatitis. He has been a multi-organ failure, but relatively stable, and quite unexpectedly just had a PEA arrest. I suspect likely a PE.
So yeah, guys, that was really, really sudden. So how's everyone feeling?
That was really frightening. Oh yeah, I didn't expect it just come out of the blue, but
yeah.
I don't even know if I did any good. I don't know, I was just so shocked in there. And was I rubbish? Was I any good? I don't know.
It's really normal to feel like that. I mean, it's perfectly normal for anything that you feel. I think the good thing to look at is, on the back of this talk, we look at common feelings. So it's common to feel shock and to feel shook up about it and upset after these kind of clinical instances. It's really important that we reflect on it and maybe don't go home straight away and try and process it before you do go home. It's really important to remember you might have intrusive thoughts, that you might have dreams about this, and if this doesn't get any better over sort of 4 weeks, then you might want to look at getting some more help. But be kind to yourself, guys. Like, be kind as you would to somebody else, and speak to yourself like you would to somebody else as well. Try not to avoid it too much. It's that balance in avoiding and sort of dealing with the situation. And consider who else might be affected as well, because you might be okay with it, but actually some of your colleagues might not, so just checking in with them as well. Yeah, it's totally optional, but if anyone wants to pop their name down and an email, and in a month's time just have a little check-in, and if there's anything more that you want to follow up with, or any questions or anything like that, that might be a really good option, okay? Thank you. Okay, yeah, enjoy the rest of your shifts now, okay?
Thank you.
So apologies if that sound was actually a little bit off there. That's as loud as it could go. So I'm just going to hand over now to Fiona, who's going to share her slides and the Bath experience.
Thanks, Julie. Hello, can you hear me there? Yeah, good afternoon. So my name is Fiona Kelly. I'm a consultant in anaesthesia and intensive care medicine in Bath.
My name's Fran Millencham. I'm a veterinary anaesthetic registrar, previously working at Bath, but currently working at the Bristol Royal Infirmary in Bristol.
So thank you very much for inviting us today. We'd like to talk this afternoon about implementing the TIM tool in a smaller ICU. Just say we've got no conflict of interest. So we thought we'd divide our little 10-minute talk this afternoon into 3. We thought we'd start off by running through why the TIM tool came about, then look at how we've been going about implementing it in our ICU, and then to finish off, look very briefly about the impact that the TIM tool has been having in our unit. So starting off with why the TIM tool came about, and there's 3 reasons really. So prior to the pandemic, I noticed that many of my colleagues seem really worried about leading a debrief and quite unsure about what to say and how to say it. And there's one particular case that really sticks in my mind. A few years ago, an elderly and frail lady had a cardiac arrest in the theatre recovery ward immediately after an operation for a fracture neck of femur. We found out afterwards that she had a very large perioperative myocardial infarction. And straight away, after the team had discontinued resuscitation, the charge nurse in recovery said to my colleague, "I'd really like you to lead a debrief now." And he said to me, he said he was really very upset. It had been a really difficult anaesthetic, a really traumatic resuscitation. He said his head was in a complete spin. He couldn't really think straight. And then he wasn't really sure about how to approach a debrief. And the fact he didn't know, wasn't sure about that, made the whole thing seem 100 times worse. So then the second reason was that even though we've got a trauma risk management, a TRIM system in our hospital, and have done, in fact, for the past 10 years or so, I noticed that prior to the pandemic, I didn't really think it was being used always to its maximum potential. And should just say, in case you haven't come across it before, TRIM is a peer support tool. Like Julie said, it fits into that nice pyramid she showed. It was developed in the military, been used more recently in healthcare, and it helps staff prepare for and recover from potentially traumatic event. So what was common before the pandemic was that I'd arrive at work on a Monday, and one of my colleagues would say, "Oh, Fiona, we had a terrible event on Saturday night. Could you please do a TRIM referral?" So I'd say, "Yes, of course, that's no trouble at all. Any thoughts about who was involved?" And it would be really difficult after the event to put together that list. It would take a considerable amount of time. And so because of that, partly because of that, I suppose, TRIM referrals I noticed were often made quite late, maybe days or even weeks after an event. Often were incomplete. They might just have first names, Tom, the junior doctor, Molly, the HCA, and often made by just quite a small group of staff. And then the third reason was I noticed, even though we had this TRIM system in place And many of my colleagues were still quite unsure of what was normal to expect after a difficult event and how to go about looking after themselves and their colleagues. So back in 2019, our trim lead in Bath and myself were planning a big trim awareness campaign in 2020. And then, of course, the pandemic occurred and all of these three worries that I had were magnified several-fold. So I do remember at the start of the pandemic, talking to our wellbeing team in ICU and anaesthetics and sharing these three concerns. And I said to them all, maybe it would help if we had a laminated card that we could read out immediately after a difficult event. It could have a prompt for writing a list of staff down. It could be have the trim email address on it, and they could have some advice for self-care to read in the coffee room after an event. And they all said they thought it was worth a go. So Fran, who's joining me this afternoon, said she'd be happy to put in place a first draft, which she did. And we worked on that. We did numerous versions, did we not, Fran, with our psychologists? And then we rolled that out pretty quickly, actually, in the first wave of the pandemic, and had really, really positive feedback from the teams. And then moving on then to October 2020, I attended an Intensive Care Society webinar, just like this one, run by Julie Highfield, all about debriefs. And I thought it was really good. In fact, I thought it was so good that I emailed her afterwards. And I thought, actually, maybe she might have some good advice about how to develop and improve our TIM tool. And little did I know that was to be the start of a 2-year collaboration between Julie and myself and the Intensive Care Society graphics design team and Sarah and the team in Cardiff. And here we are today. So this version here that Julie showed before is the sort of re-look TIM tool that we launched in autumn of 2021. And I'm going to hand you over to Fran now, who's going to run through how we've gone about that.
Thanks, Fiona. So moving on to look at how we have implemented the TIM tool. What we did was we printed the TIM tool on double-sided paper, laminated it and placed it outside each ICU bay with the debrief side visible. And then we also placed it in the coffee rooms and changing rooms with the feelings and actions side visible. We distributed the TIM tool via email, WhatsApp, and the ICU nurses Facebook page. And we also did lots of tea trolley training. This works by loading up a silver procedure trolley with copies of the TIM tool on the top and tea and refreshments on the bottom, and travelling around the ICU, providing 5 to 10 minutes of mini teaching sessions at the bedside for the nurse there, plus any other staff who are nearby. We've used this education method for numerous projects over the years, and we found that it's quick and easy to set up, it's non-threatening, it allows us to use any educational opportunities during the normal working day or night, it allows true interprofessional training, it can be tailored to the learner's level of experience and preferred learning style, and it's also pretty good fun. We emphasised during the training of the tea trolley training where the TIM tool was kept, how it works, and the fact that anyone can read it out, the importance of writing that staff list as soon as possible for the reasons that Fiona's highlighted, highlighting the hospital trim email address on the debrief side. And it also allowed us an opportunity to collect staff feedback for improving the future versions. And we asked staff if there had been any situations in the past where the TIM tool might have been useful.
I might just mention a little bit about infection control, because that's obviously really important. So in Bath, we've been really lucky during the pandemic. We've got 2 ICUs actually at the moment. So this one here on the left where Matt is, it's our older ICU where we've looked after non-COVID patients. And then we've got a newer ICU built very rapidly in the first wave of the pandemic. We've looked after all the COVID patients, and this has got negative pressure bays and negative pressure side rooms, which you go in through the donning and doffing room. So it's been fantastic. It means we've been very lucky not to have to wear sessional PPE, which I appreciate many ICUs around the country have had to do. This has allowed us to do tea trolley training out in the open ward, like Matt is here. This is Layla doing some tracheostomy tea trolley teaching with Tracy Tracy there. The same idea. I'm sure that gives you a bit of the idea. So we were very, very careful about infection control. We took clean oil wipes with us everywhere. Here's Matt doing some cleaning here. We spoke to all the relevant people before teaching just to check they were happy about this. In fact, I did so much cleaning. Everyone at the HCA's made a GIF about me doing all this cleaning, and here I am. Anyway, I'm moving on quickly and handing back to Fran now.
So over the past 2 years, we've done 123 mini staff teaching sessions involving all staff groups and roles, and looking at the staff self-reported confidence scores before and after the training. We were really pleased to see that in October 2020, there was a rise from 13 to 81% of staff happy to lead a hot debrief. And in October 2021, a rise from 43 to 92% of staff happy to lead a hot debrief. We also found that 95% of staff felt that they believed that the TIM tool would improve their ability to navigate the aftermath of a particularly difficult event. And 100% of the feedback showed they felt the ability of their team would improve with the use of the TIM tool as well. 100% of staff recommended the TIM tool to other ICUs. And in addition, although it's difficult to measure, the TIM tool does seem to have brought about a cultural change, encouraging the team to look after each other, empowering staff, and flattening the hierarchy. Looking at some of the stories, staff stories here, we've got two from ICU nurses. This first one says, "I love the structure of this. Even if I was too upset to think, I'm sure I could read this out." And another comment we had was that we like the fact that two of us could read this out together, especially when we are doing night shifts with new junior doctors. And another story we had from an ICU sister who has recently retired, but who continues to work on the bank. "I think that this could have been extremely useful to me when I was the nurse in charge, especially during night shifts. I think that the burden of looking after my team really took its toll on me, and this would have been a way of helping me to support them." Now back over to Fiona.
Okay, so just for the last minute or so, looking at trying to look at what the impact TIM tools had on our hospital, and I've got here the figures for the TRIM referrals per year since 2014. You can see the big rise in 2020 here when we launched our TIM tool. Now, obviously, I really realised there are lots of reasons why there's been a big rise in TRIM referrals, not least the pandemic. We had a new TRIM lead, a wonderful new TRIM lead called Simona Hansen started, but I like to think that maybe the TIM tool had a little bit of effect here. However, talking to the TRIM team, they definitely said that the number of staff making referrals has gone up hugely, which is good. And the time to make a TRIM referral has gone right down. It's much quicker after the event that they kept a list of staff. And the completeness of staff lists has really improved. It's quite common for them now to get a list of email addresses, which makes their job 100 times easier. So that's really positive. And then I've got the figures for October 2020 for a year, looking at number of TRIM referrals per month. And again, I appreciate that this might be a little bit optimistic on my part, but there was a big rise in TRIM referrals straight away after our TIM tool launch, which I found really heartening. I should say that we've also around this time put the TIM tool in our ICU Red emergency grab bags. Many of the ICU and anaesthetic registrars have got the TIM tool on their phones, so they get that out of their a difficult event around the hospital. The rest of the hospital seems really keen. So actually we're in the process of implementing TIM tool in theatres. Obstetrics is going to be next, maybe MAU and ED after that. We'll see how that goes. So our take-home messages today. TIM tool has been developed using feedback over the last 2 years. And thank you so much to Julie and her team for all your input. It was quite different to the first one that Fran and I looked at, I can say. We've largely implemented it in our hospital using the T-trolley method. That's worked for us. Staff feedback's been overwhelmingly positive. And just like Julie said, we found it quite useful, I think, to optimize the use of our TRIM system, but I appreciate it could work for many other systems too. And we're really keen to share. We're really interested to hear your feedback, any suggestions in making it any better. And then all remains for me to say thank you to my fabulous TIM team here in Bath, and thank you to all of you for listening. Thank you very much.
Fabulous. Thanks, Fiona.
I'm going to hand you to Sarah.
So, Sarah, just to remind you, you're muted.
Yes, so can you hear me? Just having a few technology problems in amongst all of this. So bear with me. It's about getting these. Oh, have you put my slides up, Julie?
I can share your slides, yeah.
Oh, brilliant. Thank you very much. Oh, actually, though. Otherwise, I might just be able to do that. Oh, fantastic. Wonderful. So can everyone hear me? Great. So thank you very much to the Intensive Care Society for the opportunity to be part of the webinar today. Niamh, Julie and I, well, obviously Julie's part of this anyway, but Niamh and I are obviously really pleased to be able to be part of the discussions on this. So just to introduce myself, and then I'll get Niamh to introduce herself as well. My name's Sarah Catherine Cook. I'm one of the intensive care consultants here at Cardiff, and also responsible for simulation on our critical care unit, which is sort of part of the reason I presume that I was brought into this project. But I'm also one of the associate deans for one of the associate deans at Health Education and Improvement Wales, and lead on the simulation team. And I've got no direct conflicts of interest to declare. And I will say that actually a lot of this today now is my own opinions about sort of our experiences with the TIM tool. I'll get Niamh to introduce herself briefly.
Thanks, Sarah. Yeah, my name's Niamh Sully. I am a Band 6 staff nurse in critical care in Cardiff. I'm also part of the tracheostomy team within the health board, and yeah, I have no direct conflicts of interest either.
So this is particularly amusing now because I know that there's been a helicopter outside waiting to take off, and it literally is this point that it's now warming up to go off. So please bear with me if it starts intruding on sort of the talk. But just to give you a little bit about ourselves at Cardiff Intensive Care Unit. So Cardiff and Vale University Health Board has got a number of hospitals over the course of its patch. 2 are acute, and the intensive care unit sits within the University Hospital of Wales, which is in the Heath and also sort of referred to as the Heath. We've got 35 level 3 equivalents, and our average admissions number over the last few years has been anything between about 1,000 and 1,300. We're a tertiary centre, we're an MTC, so we're a major trauma centre, and that's why, we're also sort of a specialty tertiary centre for upper GI, hepatobiliary, neurosurgery as well. And we're a workforce on the unit of approximately 400 people or so. And we've got a very interesting case mix as well. So thanks, Julie.
Are you okay there, Sarah? You've muted yourself.
Can you still hear me? So I was quite humbled really, and really pleased that Julie and Fiona approached and said, with Cardiff Critical Care, I want to be part of the team immediate needs. For me personally, it was going to be quite exciting because I was going to get to work with Fiona again and the team from Bath ICU, having previously worked there. But also, though, it was going to be a really great opportunity for Cardiff Critical Care, and Julie and I were both in agreement that the tool had real potential, benefit and assets to us as an ICU. So Fiona and Julie and I met for a couple of meetings. We further developed the tool, went through further iterations. Julie created a 10-minute video for us to be able to link people to complement the face-to-face T-trolley training we had planned. And also then sort of Fiona chatted about how they were disseminating the TIM tool across Bath and how it was working for them. And actually this was brilliant. Super excited. It was going really well in Bath, and we really wanted to have this sort of as part of our sort of what we were doing in Cardiff as well. And Niamh, did you want to add anything to that?
Yeah, so just to discuss about how I got involved. So I was invited by Julie and Sarah back last year to be involved in this initiative and rolling it out in Cardiff Critical Care. I was, like Sarah, really excited. This was something new that we haven't really seen before. And from a personal point of view, it's definitely something that I think would have been beneficial many years ago. I was involved personally in an incident back in 2019. There was some equipment failure with one of my patients, which unfortunately led to quite a traumatic death. I was extremely junior at the time. I'd barely been on intensive care a year. It was my first death on the unit. This was prior to our peer support team. And afterwards, there was no real sort of drop-in, there was no debriefing, no tools that we could use. I was able to go and have a cup of tea, and that was kind of it. So put it to the back of my mind, and then when 6 months later the inquest into this patient's death came about, and I was asked to be involved in that, write statements, and suddenly it all came flooding back, and it was really, really difficult. After some psychological support, actually it turned out all I needed, and what helped me, was sitting down with my consultant who had been on that night, going through the facts and talking about how I felt about it, and my feelings and concerns, which is exactly what we do with this tool. And just finding out that, no, actually these are the facts, and I might have, most of the feelings I was having and thoughts were intrusive thoughts that had been happening over those 6 months, was that if we'd have had that tool at the time, and I could have had that with the entire team involved in his care on that night, I probably wouldn't have had the effects going 6 months afterwards. So when I was asked to be involved with it, I was all for it, and think it's an amazing tool, especially for all health professionals, but especially for nurses. As Sarah said, we have an extremely large workforce. We have over 250 nursing staff alone, and a lot of our new staff do get lost in the mix, and being able to bring people together and just talk briefly and signpost them is really, really important. So that's my involvement, and why I'm really keen to keep pushing this tool.
Thanks, Neve. That's really, really valuable, sort of with the appreciation of how this can actually benefit individuals. But so having chatted with Julie and Fiona, and we were all very excited and raring to go with this, and actually our planned approach for delivering this across Cardiff was going to be about replicating exactly what Bath were doing, because you've heard today how well it's worked for them, and so we were going to do the same. And actually I had my first afternoon set out in our blue zone, which is our long-term complex patients, and where in fact last summer we were down to type 2R masks, and had a brilliant afternoon. Couple of hours. I think I got through 1-to-1, 1-to-2 training with 10 to 12 colleagues. The feedback was brilliant, real enthusiasm for this tool, a real support to seeing it embedded on the unit. And I thought, great. It was one of those afternoons, one of those education events where you just think, brilliant, love that. But actually, though, the reality is over the last 12 months that we have faced challenges in actually embedding this and embedding the training around the TIM tool into our ICU. And I'm sure you can understand from that, the fact that we haven't been able to embed the training means that we haven't been able to disseminate the knowledge that's needed to then be able to adopt this and actually start using it in practice across the unit. And we've taken sort of at intermittent points over the last 12 months, we sort of tried to reflect on, okay, what are the challenges, what are the hurdles that we're having to face to try and sort of implement and embed this into the unit? And actually there are a number of factors that I think have contributed to this. Firstly, we are a busy tertiary ICU. The clinical shifts are busy. There are a huge number of there's a significant amount of patient movement. There's a number of sort of activities with regards to each patient. And actually it hasn't been appropriate for us to take the T-trolley training into the clinical areas when they're so busy. It would have been intrusive and added an extra pressure sort of onto our staff and colleagues. And so we haven't been able to do that so far. In addition, I was very proud that I'd done training with sort of up to 12 colleagues and done that in a couple of hours, but the reality is that's a small number of our workforce and there's many to sort of reach out to. And actually in the majority of the last year, for many, many reasons, it's sort of been two of us that have driven on this project. And that's not because we haven't tried to recruit others to try and help us with disseminating this tool, but it's just that everybody's workload is saturated. There's extensive commitments by everyone, and that included myself with my COVID IP&C lead sort of responsibilities as well. And actually it's important to highlight at this point that from an IP&C perspective, we've got 5 areas across the unit. The majority, 4 out of 5, until very, very recently have been in FFP3 masks. And I'm not saying that we can't deliver education through FFP3, we definitely can, but it does make it a little bit more difficult. So we've been working on lots of different solutions, trial and testing different things. Julie and I have been having meetings with different staff groups, with the band 7s, with the zone leaders, with the medical trainees, with the consultants. And that's about getting buy-in, and that's been about what do we need to do to embed this into the unit. And we've been acting on the feedback. One of the key comments that really has struck me from what I've been hearing is that those people who are learning about the tool feel really empowered to ask for a TIM, but they're not actually feeling empowered to deliver and lead on a TIM, and actually feel that it's the senior staff who should be leading on this. So with that, then we have adapted our training so that we've got sessions that introduce the tool and build knowledge on it, and then other sessions which is about sort of role playing how to actually lead a TIM. But also, though, I've commented already, T-trolley training may not work for us at Cardiff, and so we've had to think about other education modalities and how we're going to deliver on this. And, you know, we've all learned from COVID the benefits of digital and online, and we're really trying to build our sort of access to education being 24/7. Julie's videos are brilliant examples of short, sharp education bites that people can access anytime they want to either learn about the tool or even remind themselves about it as well. And we try to make the dissemination as easy as possible. Some of the feedback was about QR codes. If you can't find a hard copy of the TIM, let's QR it so you can just get it down on your phone. And then Julie and Neve have been working really hard then about building up our champions to disseminate this further. So the lessons, I'm certainly not sitting here saying Cardiff's so busy, we just don't have time to do things, because actually the reality is that all intensive care units across the UK are busy. We're all under pressure. But actually, though, what I did just want to highlight today, and for us all to consider really, is that the capacity that one intensive care unit has to bring in change or a new innovative tool at any given time point might be different to another intensive care unit. And actually that's the example that Bath and Cardiff provide. Bath have very successfully been disseminating on this tool, embedding it into the unit and have it adopted. You know, and when we were discussing this last year, I very much thought, yeah, we'll bring it in, we'll get it running, it'll be fantastic. But in hindsight, I should have given more consideration to what capacity we as a unit had to be able to bring in something new. And that's about the people power that's needed to deliver on it, what mindsets and cultures need changing, but also then what other sort of competing new innovative tools, changes need to be brought in that might be more of a priority. And actually, having given that a bit more thought, I suspect we would have had a more realistic outline of the timeline we'd be able to achieve this. And actually, what works in one unit doesn't necessarily work in another. And that doesn't mean that one unit's better than another. It just means that we're all different. We need to tailor to our own local needs and adapt. And obviously, we all talk about this. It's about continuously reevaluating and keeping the enthusiasm going. Now, I have to say, Julie, I don't know how you feel, but I feel that we've achieved more in the last few weeks than what we've done in the last few months. And I just wonder if we're at our tipping point. I know and have full faith that one day we will get there with this tool, but the capacity within the unit over the last 12 months hasn't been quite there yet. But I just wonder if we're nearly there. And what I'm really, really hoping now is that our story changes over the next few months. So actually what we will be talking to in a little while is the fact that we do have more of the workforce talking about what's making them unhappy so that we can help support in making them happier. So thank you very much.
Thanks for that, Sarah. I mean, it's just brilliant to reflect on the tool, reflect on its utility, but face the reality that actually different units are going to roll this out in different ways. So we hope that that story from both Bath and Cardiff gives you some thoughts and some ideas. We've got a couple of questions in the Q&A, so if people in the audience want to add more questions, do. Just want to open it up to our panel for any additional comments before I go to the Q&A. Okay.
I just wanted to, sorry, Julie, I just wanted to add to just support what Sarah had said in her last slide. Even just over the past couple of weeks, so many questions have been coming up from the nursing staff, especially, even if it's just in the coffee room going, I saw that thing on the wall, what's that? And suddenly a big discussion comes up between everybody in the coffee room, just listening in about what this tool is. And suddenly people are starting to notice things and grab interest, even just as completing the training videos and getting people involved, that's starting to disseminate information. So I agree with Sarah that I think we might be coming up to a tipping point here where things start to come through a little bit more, which is really exciting.
Yeah, I agree.
Yeah.
I agree. Go for it, Fiona.
And I was just going to say, Julie, actually, that 2 weeks ago, I arrived at work on a Monday morning. I think I should have said this. And one of my colleagues said to me, "Oh, Fiona, we had a terrible event on Saturday night, but, Lena, one of the junior doctors, read out the TIM tool. Carlos, one of the nurses, wrote a list of staff. Kana, the nurse in charge, sent a trim referral overnight. It was with them by 8 o'clock in the morning. And in fact, there's a trim meeting planned for 2 o'clock this afternoon." And so I think you were right, Nina. I think there's a tipping point, but I feel like we're having a real, it's changed. Things have changed.
Yeah. And I think it takes time to embed that change, doesn't it? I think the thing that was key from your presentation is this has been a 2-year process for you guys, actually. So yeah, I think what we would say to people out there is don't just stick it on the wall and hope that people use it. You have to embed this tool. You have to encourage and build that confidence in the tool. And I can see from some of the Q&As, people are starting to think about that and kind of saying, well, what is the extra training? So what I will say is we in the Intensive Care Society plan a further webinar later in the year, which is going to be a simulation and a skills training tool. I haven't asked you if you'll participate yet, guys, but I'm hoping I can ask you guys. But this is something that we just recently learned that we'll be able to put on. So that's absolutely fantastic. So if you're listening today thinking, great, I've heard the experience and the theory behind it, I just want to get workshopping some of the skills and play with this tool a little bit, that's our intention later in the year. So I'm just going to go through the other questions. So Amy, who I know really well, hi Amy, has said the tea trolley idea is fantastic. A hot debrief opportunity, if the hot debrief opportunity is missed, could the TIM be used as a clinical debrief structure? And I guess I would probably come down the route of it's not a clinical debrief, but as a communication tool, I personally shouldn't see why you couldn't take that tool and adapt it maybe the next day or a couple of days later to say, let's come together, let's state the facts of what happened, let's acknowledge our feelings and what might be the common feelings and common actions. I guess I do come to your initial point of wanting this tool, Fiona, which is getting those people together and knowing who. That's a really hard thing to do in the aftermath. Any further thoughts on that?
No, Julie, I'm with you. I mean, it was one of the main drivers was get a list of staff, and it is possible afterwards, but it's really hard. I can tell you, it's really tricky, and then you always miss out just 1 or 2 people. It might be somebody who's doing an agency shift, So I think, yeah, nothing to add there, really, Julie. No.
No. So someone here is saying, oh, thank you, which is always nice. So they're just thinking about this and kind of coming back to this tool as part of their own learning, but also to implement in their unit. So thank you, Ashley, for your comment there. Another question is, interesting, is this something that might be we might be able to use with family or visitors in the aftermath? As sometimes we have a traumatic admissions and relatives reacting to sudden death or intubation and uncertainty. I must admit, I never thought about that. Thoughts, people?
Well, Julie, you're the expert here. I've never thought about that either. That's an interesting one. We should mull that one over.
Yeah. Neve, what do you think? On a
I was just, yeah, from a Cardiff point of view, we admit patients onto the unit without relatives and tend to catch up with relatives later. As Fiona said, I think it's definitely something that we can look at, and it might be a simpler way of talking to relatives and checking in with them from that point of view, because we tend to we don't really give them the option for follow-up right at the beginning of admission, when actually that might be something that they require.
Yeah.
And then referring them to the psychological first aid, that self-care component might be quite useful. We could always say, look, this is what we advise staff and colleagues about how to themselves. We can tell you this is going to be quite a stressful roller coaster sort of time for you as family. We'll try and support you as best as possible, but these are things that may also help you as well and refer them on to relevant things. I think what might be quite difficult is the facts of the case, what's just happened. But then I suppose you see it from their perspective as well. If they sort of outline what their concerns or worries are, then at least you know where you're going from there. But yeah, I think the tools to be able to look after themselves might be really useful to give right at the beginning as well.
Yeah,
and I think that's what we do anyway. But I don't think we really think about putting it in that format. And it might be actually just a really good tool for more junior staff or people who have actually never experienced an admission before, wanting to support relatives, and having that tool there for them to be able to use that and go, okay, this is the advice that I can give, and it's right here in front of me, and I can use it as a tool.
Yeah, I just want to follow on from that, Neve, because you raised that really important point that I anticipated lots of pushback of we do this anyway when it comes to the staff side of things. But actually, I got a really interesting bit of feedback, which is, I think we do this anyway, but this is how we could do it better in a more systematic and structured way and give people confidence. And that was such a lovely moment where I thought, we're not going to get that resistance when there is already buy-in, but it's about confidence. And I wonder, with the relatives angle on this, thanks for the idea, guys, definitely building the idea in my mind, but I think with a bit of rewording, actually it offers those less experienced staff or even the more experienced staff, it offers them that safe, psychologically evidenced structure for what to say. Because I think one of the key things that I find in my day-to-day practice is people say, what should I say? Did I say the right thing? And that mulling over and that regret and wondering if they did enough can sometimes be the stuff that gets stuck for people. So that in a funny kind of way, having a relatives tool would make it a staff tool as well, actually. So we like the idea. We shall definitely kind of mull that one over. I wouldn't personally advocate putting it off the wall and running it with a relative as is. Let us get back to you on that one. There aren't any other questions. I'm just going to double check this one in the chat isn't actually, I can't bring it up. I can't see any other questions in the Q&A as such, just lots of lovely thank yous. Okay, so if there is funding available to have a psychologist after each unit, or I wonder if there is funding available to have a psychologist available for each unit or a unit above certain numbers of staff, we often refer patients for psychological support. Welcome to my world. So when I started in ICU, there were 12 of us in the UK and I was one of them. There are now over 90. If you're struggling to get an ICU psychologist, I'm afraid to say it is a local funding decision. However, I wrote a business case that has gone around a number of units and has helped people make the case for psychology. So Kerry, if you just want to get in touch with me via the ICS, I can link you to that. I think the thing to say, depending on where you come from, is think about what might be the wider systems in your hospital if you don't have a dedicated ICU psychologist. You might have a trim program like in Bath. There might be a link to employee well-being in terms of kind of staff reflections, kind of wider debriefs. And certainly if people are still continuing to have the problems in that 1 month period afterwards, it's that signposting as well. So those are a couple of other things to say. There isn't a central funding pot, I'm afraid to say. Wish there were, but sadly not. I know we're just coming up to time now, so just from the panel, we haven't got any more questions, but any last reflections?
I've got one, Julie. I was just thinking while you were talking that actually Margie, our matron in Bath, talked in the pandemic about the changing room debrief. I don't know if anyone's ever noticed this, you know, how people are just chatting as they're getting changed at the end of the day and talking about what's happened and how actually that's probably been more powerful than we realise, which is why we put the TIM tool up in the changing rooms with the feelings and what to expect and useful actions side visible. So I'm wondering if maybe that might be a route we should think about going down to I think actually, like you're saying, everyone's been looking after each other already, but maybe there's a way of doing it just a little bit better, like you said earlier.
Yeah, it's that delicate balance of having this tool available in all possible places to trigger without that poster blindness and irritating people, isn't it, really? So yeah, you'll everyone listening out there will know for their own unit what works best with that. But I'm a big fan of back of the toilet door stuff, so I think changing rooms probably a good idea. So yeah, absolutely. Any other reflections or last comments from anyone else?
Julie, I was just going to say Fiona and the team at Bath should be hugely congratulated for this tool. And I think what we are probably not going to realise is not only the impact it has from sort of the team immediate meets debriefing ability and placing the facts of the case and outlining how we should look after ourselves. You know, that will be evident from the data that gets collected about how useful that's being. But actually, though, the other thing that this is going to do is the fact that it's going to get people talking about how we should be looking after ourselves, and not within any official capacity after, you know, an event that's upset us, but actually, though, just in general. And as you said, Fiona, you've given a really classic example there of people talking a lot more in the changing room, just raising that awareness, again, building on, obviously, Julie, a lot of the work that you've been doing with wellbeing, just building and adding more and more layers to the fact that, you know, we should be talking to each other, or we should be, and if we don't want to talk to each other, that's fine, but let's find a way to make sure that we are processing things properly. And this just adds to that tool again. So Fiona and the team and Fran and everyone, huge congratulations. This is amazing.
Wouldn't have happened without Julie. I can promise that. Thanks, Sarah.
I mean, you're absolutely right. You know, huge thanks to Fiona and her patients over the last couple of years working on this and bringing this to my attention. Brilliant tool, glad to be part of it. But I think, as you say, Sarah, this is the time is right for this stuff. We've really learned so much more about each other over the last couple of years and what everyone has been through, and how to make intensive care a better place to work for everyone. And I think this is a key part of that way in which we look, listen, link, and we connect to each other and look after each other when we're doing the hard but important work of intensive care. So fabulous.